All right. Good morning, everybody. Welcome to Pediatric Grand Rounds. My name is Mary Leonard. I'm department chair, and it's my great pleasure to welcome you this morning and look at this unbelievable lineup in the next couple weeks. I get to say that every Tuesday morning, but this especially is quite extraordinary. So we are so very fortunate that Dr. Thomas Lee from Ganey is going to be here, and I've been hearing wonderful stories about the interactions and the meetings he's been having with all of the faculty, and really excited to hear from him. And we'll more on Dr. Lee shortly. Want to call your attention to the fact that Tina Cheng is going to be with us next week. Tina is the chair of the Department of Pediatrics at Cincinnati Children's, but is really nationally renowned as a leader in pediatric advocacy. Health equity has been for many decades, and she and Lisa Chamberlain have done some just extraordinary work in this area. So we have a wonderful couple days lined up for Dr. Cheng to meet with a lot of our health equity folks. And she also is doing really important work on the national scale with the physician scientist pipeline. So we're going to have more interactions around that, and really excited to hear from her next week on the arc of progress in child health. And then incredibly, Peter Hotez is going to be here. And this is already creating quite a buzz. The flyer has been circulating all around campus. He's going to be giving the Richard Berman Endowed Lectureship in Pediatrics, such an important lectureship for us, on global vaccinations and the anti-poverty vaccines, the science versus the anti-science. So that I'm sure will be standing room only. So, and then on the left, we have just our usual information about CME and MOC Part 2 credit. All right, and we have our land acknowledgement that Stanford sits on the ancestral land of the Yakama Ohlone tribe. Land was and continues to be of great importance to the Ohlone people. Consistent with our values of community and inclusion, we have a responsibility to acknowledge, honor, and make visible the university's relationship to Native people. Also want to make sure, I'm going to say this every week until it is June 13th, that everyone's aware of the inaugural Stanford Medicine Children's Health Research Community event that will be held here, and really hope that everyone in your research teams, the students, the research coordinators, the PIs, will join us, because there's just a stunning amount of new infrastructure support available for clinical research, both within our walls of our hospital as well as community engaged research. And we're going to have great representation from all the teams that are here to help all of you develop, fund, and then implement your research. So please join us for this really important event. And then MCHRI, always the education committee does a wonderful job, and they have many seminars and workshops. So on May 23rd, we're going to have the qualitative research overview of qualitative data collection. This is an area where we've really needed to build some muscle. That qualitative research, we haven't had a lot of depth. We've been actively recruiting folks with that expertise, and we're really fortunate to hear from this group. And then we have the science presentation. We'll be studying human embryo implantation, a gray box of human embryogenesis. So always keep an eye out for upcoming MCHRI seminars and workshops. And then want to call your attention, the Pediatric Grand Rounds, the Pediatric Patient Safety Lectures shown here. And that, I think, is our segue to you, Grace. You're going to do our introduction, is to learn more. So this shows you the incredible lineup we've had on the patient safety lectures. And I think Grace Lee, our Chief Quality Officer, is going to take it from here. Thank you.
Thank you, Mary. So I'm Grace Lee, Chief Quality Officer, and I'm so pleased to introduce another Dr. Lee today, Dr. Thomas Lee, who is Chief Medical Officer for Ganey, and he's an internist and a cardiologist who still practices at the Brigham and Women's Hospital in Boston, Massachusetts. I wanted to highlight that he has had many leadership roles over the past several decades. He started out as an academic researcher, like many of us, conducting clinical and epidemiologic research for cardiovascular syndromes, including acute chest pain and risk stratification of non-cardiac surgery. He became a professor at Harvard Medical School and Harvard School of Public Health in 2004. Somewhere along the way, he became network president for a partner's healthcare system. And then in 2013, he joined Ganey as chief medical officer, where he's responsible for developing clinical and operational strategies to identify ways to reduce patient suffering and improve the value of care. He is currently the editor-in-chief of the New England Journal Catalyst, a member of the editorial board of the New England Journal of Medicine, a member of the board of directors of Geisinger Health System, chair of the board of the Geisinger Health Plan. He also serves as a member of the board of directors of Blue Cross Blue Shield of Massachusetts, that has had a really interesting novel pay for equity mechanism that just recently got announced, which I'm very intrigued by. The panel of health advisors of the Congressional Budget Office and the Board of Directors of Health. On a personal note, I had the opportunity to meet Tom about 7 years ago when I was taking a course at Harvard Business School. And since then, he's been a kind colleague, a friend, and a mentor to me. And so we are very fortunate to have him here to share his wisdom, his experience, and his expertise with us for this annual Lucile Packard Children's Hospital Stanford Patient Safety Lecture. We are grateful to the foundation for funding this, and the title of his talk is Building Trust and Social Capital During a Time of Turmoil. Welcome, Tom.
Thanks so much, Grace. No, it's a pleasure to be here, and my goal here is to help people think differently about their work. I think that it often feels like there are these different silos, like our workforce, well-being, there's safety, there's patient experience, there's other dimensions of quality. The case I'm going to make is that all of these fit together. There's something that ties them together, and the framework is social capital. I'm going to, trust is one of the currencies of social capital. I'm going to show you data about trust. It's a word we throw around a lot, but there's actually a fair amount known about what drives trust. I think we have to actually be aware of that, and we have to really work on that in other currencies of social capital. And the line that I have been, quoting in some of our meetings, which I really believe, is this, which is, I think we're in an era where every manager should feel like they are the CFO for social capital, and that they should be using the same intensity and discipline that the CFO uses when they try to manage the finances of the organization. Just as the CFO does not let something hemorrhage money without losing sleep and doing something about it, that every manager should do that with social capital. Now, let me plunge into a little bit about the nature of social capital, because I think it's a phrase that many people use, but there is some precision about how to use the term, and I think you're going to like the precision. I think, capital is anything that helps someone do better than they otherwise would. Financial capital are the financial resources enable Stanford to build incredible buildings like this. Human capital are the people that allow Stanford to do things it couldn't otherwise do. Social capital is how those people interact with each other and with their infrastructure that enables Stanford to do things it otherwise couldn't do. Now, I think that we're in an era where social capital is actually more important than financial capital, because you can get financial capital from the outside. You can borrow money, but no one can give you trust and teamwork and collaboration and some of the other things that we'll be talking about. Now, the figure on the right is a paper from that some of you probably know, Nicholas Christakis' paper on how obesity spreads in the Framingham study. In the Framingham epidemiologic study, they collected data in addition to cholesterol and blood pressure every 2 years. They asked people, who are your friends? Who do you talk to about important things? And so if I listed Grace Lee as a friend, that would be noted. And if Grace Lee happened to be in the study and listed me as a friend, that would be noted, and it would be a strong connection. And what that study showed was that if a friend of yours gains weight, you are more likely to gain weight, even if you don't know that friend of a friend, because norms are developing around us all the time. In fact, it went out to friend of a friend of a friend. There was still an association. Now, what social capital involves is building more connections, strengthening those connections, making those connections more effective at carrying things, and then transmitting the right information and values across those connections. Social networks are agnostic. They can spread bad things. They can spread racism and hatred, but they can spread good things. And Christakis' work showed that it can spread smoking cessation. It can spread picking up dog do in the street. It can spread altruism. And of course, what we want to spread are the norms that are critical to this organization's performance. The concrete example that I gave in some of our discussions yesterday, I brought up the concept of reciprocity in connections. And the example I gave is when I started my internship, in the first couple weeks, another intern asked me to cover him while he ran out to sign his apartment lease. And I said, well, let me check with my resident if that's okay, because at that point, no one knew what was okay. And my resident, Arnie Epstein, who's a well-known health services leader now, he said to me, yeah, of course. And then he goes, here, you never say no to a fellow intern. And I thought I spent a lot of time then, and I spent a lot of time in the year since thinking about that. And I do want to pick it apart a little bit before plunging into the data and so on. That sort of understanding, I thought, okay, I like that. No one's going to say no to me. I'm not going to ask ridiculous things, but when I have to ask someone, they will say yes. And I like being in a relationship where people knew I would say yes. And the idea that other people will say yes without needing to hear the details. That phrase stuck with me back then. And I think we all want to be in relationships like that. But now, why do we want to be in relationships like that? Well, when you start reading about social capital, you understand that in relationships like that, you're not doing it to be altruistic, to be a saint. You're not doing it because you are expecting that this other person will make it up to you sooner or later. You're doing it because if there's a group norm that everyone says yes without needing to know the details, the group performs better. The group moves faster. It makes decisions faster. You don't need to negotiate every single thing to get action. I think all of us have been in situations where you just feel like you have to negotiate every single thing, and the chances of getting everyone to agree feels hopeless. Where there's social capital, you don't have to have as much negotiation. And the analogy I would make is to financial capital. Like, money is so much better than barter. If we had to barter, like exchanging eggs for a hammer or something like that, nothing would ever get done. And that's why money was created. Money isn't anything more real than social capital. Money is an invention. And that's why they created money, to make exchanges go faster. Social capital makes interactions go faster. It's a lubricant. And so I think that, the work of developing this is part of the work which will enable our organizations to thrive. Now, one of the reasons why I think that the time is right for this is that the complexity of what we do now, I think the complexity has always been there, but we recognize it more now. The contrast I would draw for you is between back in 2013, I wrote this perspective in the New England Journal about the word suffering. And because it had become striking to me and to some of my colleagues at the New England Journal of Medicine, that we didn't use the word suffering in healthcare, but people on the outside were starting to talk about suffering all the time as people struggled with the confusion, the chaos of healthcare, and the anxiety that they were feeling, wondering if they were getting the care they needed. And at New England, I was an associate editor of the New England Journal, and I had been at a breakfast where someone used the word suffering, and I said, I got to tell you, we don't use that word at Partners Healthcare, Mass General Brigham. We try to do good things, but I can't remember the last time that we set a goal for reducing suffering. So it was a Thursday, and I went to lunch. On Thursday afternoon, the editors meet to go over manuscripts and inflict suffering on authors from all around the country and world. But before that, we had a few of us would always come and have lunch, and I described my breakfast, and they all agreed they didn't like the word suffering either. And we talked about, okay, what is that bugs us about the word suffering? And as we talked about it, the lead copy editor, Deb Molina, who now runs the perspective section, she pointed out, she said, you realize that human beings are not allowed to suffer in the New England Journal of Medicine. And we said, what do you mean by that? And she said, all the good journals use the AMA style guide, which says, avoid the use of overly emotional terms such as suffering. So that if you would have written the patient suffered complications, they would change it to the patient experienced complications, something less heart-rending, because they just don't want to make people feel guilty. So my colleagues thought that was interesting enough that they said, write a piece about this. And then the New York Times picked up it, and Gina Colada did. She ran a front page story about the word suffering and how people were starting to use it. And then she ran a second piece on it. So that was like big news back in 2013. Well, given everything we've gone through, I would say in the last few years, we have a much more nuanced understanding of the ways in which people are suffering now. I mean, it may feel like civilization is collapsing at times, but I actually think we get the pain that people are having in a way that we didn't before. And it's not just patients, but it's caregivers too. The equity, focus that many of you have. I think that, since the murder of George Floyd on May 25th, 2020, all of us have thought more deeply about issues. And I'm going to show you some data relevant to respect. It's one of the things that flows out of this. There are many organizations now that are actively working to try to create a culture of respect. The phrase "respect should be like hand hygiene" is being used in many institutions now, where every employee, every patient is treated with respect. There's mitigating fear. I'm going to show you a little bit of data on basically the emotional harm that comes from when patients don't feel that they're safe on an outpatient basis. The data will be on an outpatient basis, but it applies everywhere. I mean, it's one thing to keep people safe, but keeping them feeling safe is a second issue and a real issue. There's giving hope. One of your colleagues brought that up in a meeting yesterday that some of my colleagues and I wrote a piece about how giving hope should be a high reliability function. I won't go deep into that today because I want to focus on some other things. Well, paramount among them, building trust. Now, trust is a basic currency of social capital. But before I get to the data on trust, let me step back and say 4 or 5 slides that are sort of more academic, intellectual comments on social capital and the strategic context for thinking about it. The term social capital has been around, but it really became widely used in the year 2000 when this book, Bowling Alone, came out. And I don't know how many of you know this book, probably some of you do, by Robert Putnam. And it's, the title, the cover is so haunting. The title comes from the observation that more Americans are bowling than ever before, but bowling leagues have collapsed. People don't do things together anymore. People are actually bowling alone, but they're also not going to parent-teacher associations anymore. Membership in churches has dropped below. It had been declining. It was at 70% in the year 2000 when this book came out, and it's below 50% now. Tewksbury High School, which is a high school near where I live, they only had 4 kids turn out for the marching band. So people just aren't, the things that used to constitute social fabric are frayed, and it has a lot of consequences. And now Putnam is actually an optimist. He notes that there was similar isolation around the turn of the last century, and then with the crises in the middle of the 20th century, the Depression, World War II, social fabric really strengthened, but then it's been declining since. Now, we have our own version of bowling alone type problems in healthcare today. And I'll point out dynamics which I think are familiar to all of you. I think the older you are, the more you appreciate the loss of the social fabric that many of us grew up with in healthcare. The work of healthcare has become great because of incredible progress, and much of which comes from within several miles of where we are. But it's become incredibly busy. We can do so much. We have a lot more running around to do, and ironically, and it takes many more people. But ironically, with many more people, it's lonelier now. You don't do things like walk down to the radiology suite to look at x-rays together and discuss them as a team. And something was happening during those times where you would like press the elevator button waiting to go down, even though it was already lit up, and that we took for granted. But some bonding was happening. There's so much to do. No one can do first-rate care by themselves. But the fact is, we all know teamwork's spotty, chaos is common, friction is the norm for patients and caregivers. Every patient's become a big data problem, and caregivers are sitting by themselves looking at computer screens all day long. Taking this on is, building social capital. Now, I went through at the beginning how social capital is something comparable to financial and human capital. The examples: teamwork, high reliability organization cultures within teams, reliable use of information and information infrastructure, like for example, as you begin to adopt AI, chat GPT, like innovations, everyone doing it, that is a social capital norm. I'm going to give you other examples of social capital as we go on, but there are these currencies, like there's trust, and trusting each other, and not like information may travel across those connections, but then is it going to be believed? Is it going to be responded to? You need trust on the recipient end. Engagement and alignment. People need to feel proud of where they are, and they need to feel alignment, meaning like they believe that their boss has the same values as they do, and their boss's boss and their boss's boss, all the way up to the senior levels. If you have got, and that's harder as organizations get more complex and people don't see each other, but that when you've got that kind of alignment, the organizations work better. And when you don't have that kind of alignment, when you've got frontline managers that throw senior managers under the bus, saying, well, what can you do? They have no idea what's going on. That's a problem. You can't have those things without respect. So there are two basic tools for building social capital. One is brokerage, where you increase variation within organizations. Like you learn from the different parts of Stanford. You learn from places outside Stanford. People doing patient experience learn from people doing safety in terms of like responding to events which cause emotional harm. So learning is through brokerage is one important tactic. Another is closure, where you reduce variation, where you nail it down within a group that we're all going to do it this way. And that requires trust then, in the leaders at the front lines. So you need both. You need those tight bonding connections within a group at the front line, and you need the learning that goes with being open and receptive and developing relationships and taking information from the outside. Now, this is why I think this sort of line of thinking is so important these days. This next 3 or 4 slides is like a little bit of a business school seminar, but I think that it'll add something. All right, so I've worked a lot with Michael Porter at Harvard Business School, who I think it's fair, most people would say he really contributed a lot in over the last 35, 40 years in terms of redefining how people think about strategy in healthcare. Now, and Michael and I have talked about this, and the specific question about why are things so hard these days? I mean, I think many of you will hear leaders say it's never been this hard. And the truth of the matter is, I really think they're right. I think it's never been this difficult. And I don't think it's going back. I don't think it's the pandemic. I don't think it's anything transient. And Porter and I have talked about this, and we feel that there's been an intensification of the competitive pressures that he described as the 5 forces in a famous paper he wrote in 1979. Now, what the 5 forces, what Porter did when this was like his first big contribution, and how should organizations think about competition? He'd already sort of laid out that in order for an organization to be thrive, it needed to create value for some customer. It needed to make the world better for some clearly identified customer. But he noted that even if you are creating value for some customer, you might not get rewarded. And every organization, for profit, not for profit, needs to make a margin until it can invest for the future. And you might not be able to make that margin if your competitors erode your ability to have a profit. So the traditional way of thinking about competition is in the middle, the rivals that are like you, other pediatric hospitals, other kinds of, physician groups or something that might be out there. But what Porter did is point out that there's more forms of competition than that, competition for your profits. The power of the purchasers. If the purchasers have tremendous power of you, if they're consolidated, if the only purchaser is the government, they can decide what price they're going to pay you, and you may not be able to have the profit you need to thrive. If the suppliers have tremendous power over you, there are shortages of personnel like nurses, anesthesiologists. They can erode your ability or erase your ability to have a profit. Drugs, devices. So that's the power of suppliers. There's new entrants like so when Amazon allows any Amazon Prime member for $9 a month to become a One Medical member and get 24/7 consultation from a nurse practitioner, that's a competitive threat. And then there's the ability to meet needs in other ways besides traditional vehicles. So what Porter feels and what I feel is that the world has changed and there's no going back. There's consolidation among purchasers, consolidation among suppliers. There's a wave of incredibly expensive high-cost drugs coming down the pike. And it's going to affect the ability of any organization to have a margin. So one of the things that Porter has said, and then he and I wrote about together in an article in the New England Journal, was how this famous phrase is strategy is the antidote to competition. When you have to analyze what the nature of your competitive threats, think about the 5 forces, but then you can't panic and go home. Certainly, and especially if you're already running a healthcare business, you need strategy, and you can't outwork, the 5 forces. You can't outrun them. You can't merge with everyone in sight because even if you did that, you still got the other 4 forces. So the response has to be strategy. And in this article and other articles, the distinction that's critical is between operational effectiveness and strategy. Where operational effectiveness is doing a better job of what you currently do, doing it more safely, hiring better people, using best practices, taking waste out of the system. And that is still 90% of management, doing better at what you do. But strategy is about making choices about what you're going to do and what you're not going to do. Strategy is painful because when you make choices, you make people mad. And we don't like making people mad in healthcare. We are nice in healthcare. We don't like conflict. So we're not good at making choices. But I think it's obvious when you ask, would you rather be in an organization that can make choices versus one that cannot? Of course, all of us want to be on a team that wins and that thrives. So you want to be on a team that can make choices, but you don't want those choices guided by politics, like who has the loudest voice, who makes the big donation. You don't want it guided by what makes the most money under a fee-for-service payment system, because that payment system is transient and it ultimately is, and those will be the same choices that your competitors are going to make. Porter established strategy boils down to 2 simple questions that should guide your choices. One is, what value are you creating for whom? and who's your customer and how are you making the world better? And then the second question is, how are you going to be different? What's going to be your competitive differentiator? Because if you're doing the same thing the same way as everyone else, ultimately markets do work and you will be in a price war and you will not be able to have a margin and you won't be able to thrive. Now, what we wrote a paper in actually 2013 now in Harvard Business Review that ended up being the most cited and downloaded paper, that more than all of my other papers together. I actually have calculated this. This paper has been, had 730,000 online uses at HBR, and we put out this framework, social capital, which showed a strategic framework for what organizations should do to pursue their strategies, and there's no evidence for this. This is just two guys sitting around on a Sunday afternoon saying what they thought, but it's the best we could do. But it seems to have been useful. I mean, you can tell, like, I made that figure and you can see the arrows don't quite touch the balls, very well. I mean, after like about an hour, I got fed up and I gave up trying to make the arrows look good. And I say that just so, to be appropriately humble, there's no evidence that this is the right approach. And, but it's the best that we could do. And the article seems to have been proved pretty useful. I mean, I'm not going to go into I would adapt the language that's in those various balls to say, basically, we are saying you need social capital, you need great teamwork, you need to be measuring what actually matters to patients, you need incentives for improvement, like not just financial, but transparency and non-financial incentives. You need to be looking across patients' whole journeys. You need high reliability systems, and you need an infrastructure that supports high reliability and high value. Okay, so with that sort of context, let me show you some data relatively quickly. Okay, first, like this is going to be information about what we know drives trust in the workforce. And this is like drawing from Ganey's national data sets. When we look across employees and how engaged they are, engagement is 6 different statements that we roll into one, and it gets at like, how proud are you? How proud are you to be working in healthcare at Stanford Children's, and to wear a Stanford Children's fleece when you go out there, to the supermarket. And everything we do is on a 1 to 5 scale, where 5 is good and 1 is worse. It's terrible. And you can see that the medians fell during COVID, like 4.14 down to 4.02. But what's more important is that the spread in variation between the 10th and the 90th percentile. The truth is about 1/3 of organizations got stronger during the stress of COVID, and about 2/3 got worse. So what you do really does matter. It's not like you're doomed because of a pandemic sweeping the country or whatever comes next. Now, when we look at our data about the big drivers, there's data behind every one of these points, but I want to give you the high-level messages first. The first is that pride really, really matters, and there are 3 different flavors of pride. One is pride in the overall organization. A second is pride in the work that you do as an individual, and then there's pride in the team that you're part of. And I'll show you data related to that. Alignment is important. Again, alignment is something different from engagement. Engagement is how proud are you to be working at Stanford Children's, doing the care that you're doing. Alignment is more personal. Like, how do you feel about your boss? How do you feel about your boss's boss? And all the way up to the top. And if you don't feel good about alignment, or if frontline managers are throwing senior management under the bus, that compromises trust. DEI, as I said, it sort of evolved into a focus on respect, and I'm going to show you some data on that. I'm not going to talk about resilience. First, that would be Coles to Newcastle. You've got Tate Shannonfeld here, and he is my friend. I've also got another consigliere on this, with my cousin Angela Duckworth, who I quoted a lot yesterday. Tate and Angela are my 2 the two people I've learned the most from regarding resilience. But maybe we'll come to that in discussion, but I'm going to focus on other things. Now, the first thing, I know there's the print's really small here, but like I think you'll take away the qualitative message, and that this is based on a ton of data. This is based on like 410,000 employees across the country, and it's looking at what are the risk factors for people wanting to leave, which I think is a marker for their trust that their organization is going to take care of them. It's basically based upon our engagement data. And this does vary from organization to organization, but this is when you roll everyone together. The most powerful risk factor for people saying that I'm ready to look around. I'm not necessarily likely to stay with the organization for 3 years. I'm not necessarily going to stay with this organization if offered another job. The most powerful risk factors are pride. That's what you see at the top. I like the work I do. My work is meaningful. My work makes a real difference. The organization provides high quality care and service. The organization conducts business in an ethical manner. And then you get a little further down, you see things about the teams, and you see things about respect. The person I report to treats me with respect. The organization treats me with respect, and so on. So way at the bottom, out of sight, because we had to cut it off, are the things we talk about all the time: compensation and adequacy of staffing. They're risk factors for losing people, but they're weak risk factors. So like the fairness of my compensation was 1.6, and adequacy of staffing was 1.4. I mean, of course, we have to do all we can to pay people fairly and staff adequately, but that's not the main reason we lose people. We're more likely to lose people because of things related to pride, things related to basically to social capital. And that's because it's not like other people are going to be able to pay them better or staff better. When you break it down by job type, this is the same 410,000 employee data set, and color coded. You see things like the light pink, seeing every patient as an individual, patient-centeredness of care. When I first saw this, I said maintenance workers and security guards have patient-centeredness as their most powerful risk factor for being ready to look around. And I asked them to recheck the coding, and the coding was right. And one of my colleagues, actually a former protege of David Entwistle when he was at University of Utah, she said to me, she believed it completely. And she said, Tom, like when patients aren't happy with their care, they don't yell at you doctors. She said, they take it out on everyone else though. And when they really feel great about their care, they are thanking everyone. They're hugging the clerk on the way out. They're saying things to the security guards like, you must be so proud to work here. And those security guards, they don't get that in their life that much. They don't get it if they went to Burger King or Best Buy. And that is why they stay in healthcare. So the soft stuff, the pride stuff matters not just to the people doing frontline care. It matters to, and I actually think the further you are from routine day-to-day patient care, the more important the pride stuff is. I'll skip this stuff we have plenty of data just showing all these good things go together. Like this is safety culture and DEI culture. The good things correlate with good things. Okay, I promise to say a little bit about respect, which I think is so critical. We find that when we look at that statement, this organization treats me with respect. It's like a tale of two cities. Or at least there's a big spread. Managers and physicians tend to be pretty high up there, but then you get down there to nurses, and almost everywhere, nurses are at the bottom or near the bottom. Maintenance workers, security guards are near the bottom. When we've explored this, I've told a number of people here about this, experience I had at Capital Health System in New Jersey, where I showed this and I asked, does this data seem like it might be relevant where you are? And the vice president for that oversaw housekeeping and escort service spoke up first, and she said completely. She said that my employees, most of whom are women, most of whom are minority, tell me that they feel invisible. You know, one woman said, I've been here 20 years, and I can't remember the last time someone actually used my name. And she said, they said, people only talk to me to yell at me. And she said, my people tell me that people throw trash on the floor right in front of them as they're doing their work. So they were mortified, you know, they were inflicting emotional harm on colleagues right in front of them. And so now they're undertaking an effort that they're going to try to change that. They're going to take these 250 people, they know who they are, they know their baseline level of how they feel about being treated with respect, and they're going to see if they can move the needle on that. And then their hope is they can do that it might spread. You know, they're going to, you know, the nursing unit leaders are teaching the nurses that we say hello when they come on the floor. We learn their names. We thank them when they're done. And that if we can do that, their hope is that will move the needle. We'll see. There's good reason to do it. I mean, you know, it's not just to be nice. It's, you know, performance. You know, you want to retain people. And when people, you know, say that they give a low answer for this organization treats employees with respect, those people are 7.6 times as likely to say, I'm ready to look around. And when people say they're ready to look around, about a third of them actually do leave over the next 3 years. We also find that, like, the figure on the far right shows that when you divide organizations into quartiles, based upon the response to employees about the culture of respect, patient experience correlates tightly with it. You know, we find this over and over again. Basically, good things in human experience go with good things in human experience. You can also see in the left-hand side, the treatment of employees with respect is the #1 driver of employee engagement. So a culture of respect is a good thing to go after. Just a couple things about patients, and then some final sort of advice. First, and I've showed these data at Stanford before, although I don't know if I've done it at Stanford Children's. And this was the first thing I did when I got the Press Ganey, when I took the same sort of methodological techniques from my clinical epi career in chest pain and this recursive partitioning analysis for those of you who are statistically minded for these big data sets. And so this is 937,000 you know, ambulatory patients, and looking at what drives their trust, with a surrogate for trust is likelihood to recommend. And what you can see is only 15.7% of patients did not give a 5 on a 5-point scale. You know, patients want to trust us. But then the statistical tools, you know, separate the group into 2 groups with the biggest diversity in outcome rates. In this case, failure to trust. And so you can see the #1 variable was confidence in the clinician. So having good people who are acting like good people, who are wearing, you know, a Stanford Children's white, you know, logo. That's the kind of thing that gives people confidence. So that's the most important thing by far. But then the statistical package keeps on going and looking for what creates diversity in the subgroups, and on until it can't create spread anymore. And what you see is the next variable is teamwork. You know, and so, like, if people feel like they've got good people who are taking care of them and they're working together, there's a 1%, only 1%, less than 1% were not in love with their care. But if they don't feel like the coordination is excellent, then they, you know, they're less confident. And there's 11-fold increase. And then there's a variety of forms of empathy and communication. So the people want good clinicians who are working together, who are showing that they care and are communicating well. I mean, that seems pretty reasonable. But it's not the only thing, because in our recent years, we've done, our analyses have shown patients are really unnerved by friction. I think that they know now that systems are taking care of them. And when anything goes wrong, it shakes their confidence. They're thinking, what else? And then there's a sense of safety. I'm not going to talk about the teamwork or the trust in new models, because I just want to show you a little bit of one slide for each of those two things on friction. Like this is from a very good, provider organization, and 10,000 ambulatory surveys. They're in the 81st percentile, really excellent. 94.4% of their patients gave a top likelihood to recommend. But what you can see is that 55% of their patients had a completely smooth course, at least according to how they commented on what happened. They could reach the practice, they could get an appointment, the instructions were clear, and they loved their care. They were in the 99th percentile. But 45%, 44.9%, and incredible for our industry that like half of people have bumpy roads. They couldn't reach some kind of friction. They couldn't reach the practice. They couldn't get an appointment in the time frame they thought they needed it. And they were in the 18th percentile. So the things happening, the friction and chaos, even before they walk in the door, is separating people into two groups that love you or hate you. And you can recover, but it's tough to recover. So systems matter, and people are tuned into that more than ever before. The other thing I wanted to emphasize is that the perception of safety matters. People have not really worried about safety on the outpatient side. The safety movement's not that old, and the inpatient sides where we've had infrastructure and where patients are frail and we're doing audacious things to them. But most people are not, inpatients. Most people are on the outside, and everyone is scared these days. And so we added 4 optional questions and a comment box to our outpatient surveys. And I don't know whether Stanford Children's uses them or not. You don't use them. But what we found is that this is 14 million patients, a subset of our overall database for the year through May 2023. And you can see that subset overall was in the 43rd percentile. 82% had no safety concerns, but 17.6% did. And you can see that 17.6% was in the 1 percentile. And when we looked at the subset of these patients who rated everything perfectly about their doctor, they're in the 2 percentile. So if patients are concerned about anything about safety, it's a hole you cannot get out of. So, when I looked at the comments, we use natural language processing to look at all the comments. There are things like, they would see like a Band-Aid on the floor with a spot of blood on it. Now, I think they kind of know that, a Band-Aid with a spot of blood is not going to hurt them, but they're thinking, yuck, what else? And there are a whole bunch of comments about the doctor or nurses wearing scrubs, which had some kind of blood or fluid stain on it. And I felt really guilty when I read that, because I know when I was a cardiology fellow, I know that we kind of thought it was cool to go up back to the floors with blood on our scrubs. And we just thought that was macho or something. And patients were probably disgusted then, but they're really disgusted now. So, all right, so let me wrap up with 2 slides, and which is, okay, so how do we use those connections and strengthen those connections with reciprocity and other tools? There are other things to strengthening connections, transitivity, having the people, connected to each other as well as to their boss. But then how do we spread the right things across from them? How do we make certain things a norm? And I commented on this I've commented on this in a few meetings since February when I first started talking about social capital. And I draw upon my Chinese background. I was born and raised here, but I think it's relevant about thinking about rituals. Now, Confucius was a Chinese philosopher almost 3,000 years ago. And I think, philosophy is about that quest to try to be good, try to be better than you are. What does it mean to be good? And, the contrast between Confucius and Western philosophy, that many people draw is they're more Western philosophers who really believe in rules. Like, the famous example of Immanuel Kant saying, never lie, even if it would save someone's life, you shouldn't tell a lie. Confucius would have said, well, I don't know about that. I'm pretty sure that would have been his answer in Chinese. He felt life was complicated and it's tough to come up with a rule that's the right thing for every situation, just as it's tough to come up with quality measures that are the right thing for every situation. But he believed in rituals where, these frequent, regularly occurring events at which we behave as if we are the way we should be. You stand up when an elderly person enters the room. You sit down when a patient is in a bed to get down to their level. You greet colleagues like the housekeeping folks by name, and you say thank you when they've done their work. And what Confucius believed is if we behave as if we are the way we should be in those frequently occurring events, and we do it with high reliability, and there is the pressure of other people around to give us negative feedback if we don't behave as if we are the way we should be. He believed if we do that, it will hone our instincts so that we are more likely to be that way in the gray zones that make up most of life in between. I mean, once I got tuned into this, I make myself hold the door for other people to walk through, even when I really want to get someplace quickly. And I let people off the elevator. So this thing about acting as if you're courteous and respectful, there's something to it. But it means that your managers need to be able to enforce those norms with the same discipline they take to hand hygiene today. So my last slide is, okay, to be a CFO for social capital for your unit of the organization, I think there's real work to do to really strengthen the connections among the nodes in your network, and then spreading the right norms. I mean, I believe that every manager should round on 2 of their reports every shift, like every day, so that, and not the same 2 people you like, but, in the course of a week, you should be, or a week and a half, you should touch base with all the people who report to you, and, comment on the things that, are important for the organization. And you should act like a CFO. You should be measuring what matters. You should be prioritizing opportunities to improvement, create plans, react when you're hemorrhaging social capital in some place with some people, and you should implement and monitor your progress. I do believe that the term social capital, some people say, oh, why are you making this like money? It's because this needs the same intensity of attention that money gets. And so that's why I would say that, considering reframing the work you do as building social capital and then building it is a good strategy for the future. Okay, so with that, that's the end of my slides, and I'm thrilled to have a chance to show it to you. And I think we got some time for questions and comments. Grace?
You. Do we have any questions? I have one online, but before actually I take any questions, I wanted to just acknowledge that we had the opportunity to take Dr. Lee out to dinner last night, and he actually helped us build social capital. It was so interesting. He asked us what would make him super jealous that he wasn't at Stanford. And there were 20 people around the room who just expressed such immense pride in the organization. It was amazing. I have to say, I love that exercise, partly because you realize sometimes things are hard, sometimes things are broken, but when you hear about all the amazing things that people are proud of, it actually gives you a new sense of pride in our people and our organization that I thought was lovely. So,
well, and I thought what was bringing everyone together was the desire to inflict pain on me by making me feel bad that you were doing so many cool things and we weren't.
What questions do you have?
Yeah.
I'm Steve Roth. Had the pleasure of joining you last night for dinner. Wonderful presentation, very thought-provoking, Dr. Lee. In your experience, are there any systems that already exist, infrastructures or processes that you think are particularly good at promoting social capital? What comes to mind here is we adopted the lean management system in an effort to use standardized approaches to our work every day. That's one place in which I think we could do this. you think there are other systems that you've seen or practices that would be particularly good at promoting social capital in an organization like ours?
Well, I do think, and I know Steve's in good spirits because now he knows the Celtics won, and he wouldn't let him know the score during the game during dinner last night. No, I think the term social capital actually hasn't been used in healthcare. So I feel pleased about that. I started a book called Social Capital in Healthcare, which I hope I can finish by the end of the summer. But I do think that it's not really, if someone says, oh, he's just repackaging something, they'll be right, because I think there's no difference between, like high reliability, principles, and there's no different, and like a lean management, Six Sigma type things. It's all very much part of the kinds of things we need to build and spread. I think calling it social capital to me, it's like my effort to try to make this as tangible and real and strategic to leaders as financial capital. And I really do believe it's more important than money in terms of differentiating which organizations are going to do great. And especially because of that observation I made at the beginning, we're in a time where money and people are constrained, so we better hit it out of the park with social capital. And then the other things, I think I want managers who are not in the C-suite, but closer to the front lines of care, to feel that their work is really strategic for the organization, and you've got to be disciplined and intense about it. It's not like well, I've done what I can. The CFO would never go, I've done what I can. You got to think, what can we do? And you keep on working at it. So I think that it is a repackaging, but the discipline that goes with lean, it's fantastic. And I can give you some cool examples of people who have taken lean and adapted to reducing emotional harm, trying to reduce unnecessary wasted fear. So that the example I'm thinking of is breast cancer screening programs where women all get offered core needle biopsies the same day, when they're told that they need a biopsy. You can do that. It takes management and so on. So, but the idea of taking lean management and applying it to wasted fear, there's cool work to be done. That actually is a brokerage thing where you're taking something from one area, lean, and applying it to a new area. It's the cool stuff that makes us all happy.
There's one question online that says, this is a very provocative lecture. Social capital is a valuable asset, and people shouldn't really give valuable assets away. But asking, what happened to our social capital? Have we lost it, spent it, or had it stolen? And questioning, when social capital is spent, who benefits and who is suffering from this?
Yeah. Well, I think social capital is down in society in general, and that's what Putnam's book Bowling Alone was about. Now, Putnam, his most recent book is actually called The Upswing, and he is an optimist, and I am too. I think most of us. I actually think managers, and we talked about this yesterday in one group. Managers and leaders, you have to be optimistic. You've got to be thinking there's a possibility we can get better. And Putnam believes that just as social capital has gone, up and down in the past, it can go up again. It will go up again, and it's our duty to build it. Now, I think social capital is different from financial capital in one important way, which is when you spend money, it's gone. When you build social capital, you get more social capital. There's good data to support, like when you take individuals and you connect them more to each other, you end up with teams that have more social capital. And when you've got teams that are tighter with more social capital, you have individuals who have more social capital. It is like there's virtuous cycles It's a renewable resource, source of energy here. So I think that it's, I don't see any evidence of trade-offs in that, like we find in our data at Press Ganey, when you build this in the workforce, patients appreciate it. That correlation I showed you, there are many more things that like that. And when you look at what patients value, they value teamwork. Employees value teamwork. They value commitment to safety. We value commitment to safety. So I don't think there's any price to be paid. This is win-win, but it takes work. You can't take it for granted, and it takes and having discipline. Like, I can tell you that Capital Health, that place is going to try to make the maintenance people feel appreciated. The nursing unit leader, some of them are saying, I don't know how to tell people be respectful to other people on the floor. They're nervous about telling people. They would have been nervous about telling people to do hand hygiene in the past, but now they've got to learn that enforcing other norms is important. So it's not like you can just assume it will happen.
Thank you. And so I'm just going to close with, as an infectious disease doc and as somebody who is responsible for our core goal deployment, one of the things we put up and make very visible is hand hygiene. And we actually have secret shoppers that catch people in the act of hand hygiene. So I'm going to actually urge all of us to be secret shoppers on thinking about respect and putting that up on the dashboard and saying, how do we catch people in these moments of kindness and respect to other people? And being able to call them out on it, I think reinforces that social norm and that social capital. So yeah. I want to thank Dr. Lee for his time today and thank all of you for listening and appreciate your presence with us today.
Okay.